Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so delighted you could be here with us today. Our first illustrious guest is Dr. Sam Melton, emergency room physician. Dr. Melton, thank you so very much for being here.
Thank you for having me.
Dr. Melton, I understand that you are a local boy that went away and made good. Now, where is it that you grew up?
That's right. I grew up in Carmel Valley, and I went to Carmel High School.
What year did you finish at Carmel High?
1994.
Awesome.
Yeah.
And then where did you go to medical school?
USC in Southern California, Los Angeles, just like you.
I love that. I've had a run of those guys on the other side of town from UCLA, and I'm forced to talk to them. But
yeah, we don't talk about them.
Right. So you finished medical school at USC, and then what?
And then I did an emergency medicine residency training program, also at USC, at the big downtown county hospital.
LA County, USC, exactly. Great.
Yeah.
Dr. Melton, it used to be that emergency room physicians were sort of doing like night call or sort of moonlighting. In other words, they had another specialty. Primary care doctors or surgeons could take call for the emergency room and help the nurses there, et cetera. But now there's an actual board of emergency room medicine. Isn't that correct?
That's exactly right. Ever since, I believe, 1971 maybe, we've been our own specialty, just like orthopedics or pediatrics or general surgery. And we do a residency dedicated to emergency medicine, and we train in pediatric, adult, and gynecologic emergencies.
Well, Dr. Melton, so let's just imagine we have a high school student who's watching the program.
Yeah.
What type of person seems to be good at running the emergency room and working as an emergency room physician? In other words, who do we encourage to consider a career in emergency room medicine?
That's a great question. I always tell my friends and family that being an ER doctor is more similar to waiting tables than it is different. You need to be able to multitask. You typically have anywhere from 6 to 10 patients that you're taking care of at once. And so you need to be able to keep multiple things in your mind at the same time and pay attention to multiple different problems at the same time and be efficient. And triage is really the number one thing we do, which is make sure that you're dealing with the most life-threatening problems first.
Dr. Melton, I recall from my training at USC where I was chief resident and I did a microsurgery fellowship and a hand fellowship and a cosmetic surgery fellowship. Sometimes I would moonlight in emergency rooms, but I would take call on the surgery side. One of the things that impresses me about you guys is in one shift you can see a gunshot wound, a car accident, a baby that with a bellyache. You could see a bad flu or cold. You can see chest pain, which we're going to talk about.
Exactly.
So it's an incredible spectrum of problems and pathology and psychiatric problems that you people handle. Isn't that true?
Exactly, and that's one of the main reasons I chose the specialty is that you really get to see all the problems and work with all the problems that you learned about in medical school. And oftentimes you get to be a diagnostician, meaning you hear what the patient has to say, you examine the patient, and not all the time, but some of the time you can make the diagnosis, which is very satisfying.
Well, Dr. Melton, I very much appreciate you coming on the program, and I want the audience to know that I think we're very lucky to have your group cover the hospital in town. In particular, I asked you to come on because I knew you'd be a good teacher, and I think you're really excellent. You're an excellent thinker, and you approach problems very logically, and we appreciate that.
Thank you, and I want to thank you for having me, and thank you for all you do for the community, too. I also want to say hi to my daughters, too, if that's okay.
How many daughters do you have?
2 daughters.
You have 2 daughters?
Yeah.
So local boy, you grew up in Carmel Valley.
That's right.
Went off to USC.
Yeah.
Oh, and you returned to help run the emergency room. Dr. Melton, that's awesome.
Yeah.
One of the issues that I'd like to talk about, which I think is very important to teach our audience about, is chest pain.
Yes.
And I think that, you know, the dreaded coronary artery disease can present as chest pain. But of course, not all chest pain means there's a cardiac problem.
Exactly. Right?
There can be problems with the sternum and the pectoralis muscles. If a guy or gal works out hard, there can be reflux, there can be pneumonitis.
Exactly.
So let's start by teaching our audience what doctors mean by this phrase workup. Like when someone comes in and they're complaining of chest pain, what do we mean by, or if we say to the nurse, we need to work up this symptom or work up chest pain? What do we mean by workup?
Yeah, that's a great question. A workup is something that we do all the time in the emergency room. And what it means when we say we're going to work this patient up or we're going to do a workup, we're just talking about we're going to run tests. We're going to run a series of tests that will help us make the diagnosis. That's all we mean. Usually when we say that, we mean that we are planning on heading down a fairly extensive series of tests that will usually take a few hours to result, anywhere from 2 to 4 hours.
Okay, so I think that's key. Now, Dr. Melton, isn't it true that the first step in taking care of somebody or evaluating someone with chest pain is to take a history and to examine them, and then you're going to decide what tests you want to run? Isn't that correct?
That's exactly right.
So what are some of the clues that you listen for? Let's say it's a 24-year-old woman who at CSUMB is getting ready for a special athletic event in 6 months, and she's doing a lot of weight training, and she comes in complaining of superficial right-sided chest pain. That might be different from a 65-year-old man who was working out in the yard and all of a sudden felt short of breath and some pressure on the chest. Isn't that correct?
That's exactly right, yeah.
So tell me more about what you listen for when you're evaluating chest pain.
Okay, and chest pain is actually one of the areas where history is useful, but not as useful as in other problems, such as abdominal pain or headache or dizziness. It is still very important. So some of the things that are most important that we look at is, like you said, age. I mean, the most obvious history finding there is, what is the patient's age? Is this, a 10-year-old healthy kid? Well, then it's almost impossible. We never say impossible in medicine, that it's blocked arteries in the heart causing the pain. Whereas if it's like you said, a 65-year-old man, a smoker with high cholesterol, then it's much more likely. And that's really when we examine and we see someone with chest pain, that's really what we are focusing on, is how likely is this to be a serious cause of chest pain. And some of the other questions we ask, what does the pain feel like? What we call typical chest pain, meaning pain from a blocked artery in the heart, usually lasts a few minutes. It's usually pressure-like or squeezing, and it can be relieved with nitroglycerin if people have that at home. Those are some of the history findings that have been most reliable. But unfortunately, chest pain is very hard, and you often cannot rely on just history to tell someone your chest pain is not serious. You need to perform tests.
Okay, so part of your examination, part of your workup, does that include a physical exam?
Of course, yes. Absolutely.
So what are some of the instruments you use, and what are things that you look for?
So obviously we use a stethoscope to listen to the heart, and what we're listening for is murmurs, mostly, and heart sounds to make sure they're normal. We check pulses to make sure that the patients have normal circulation.
And with the stethoscope, you can hear some of the lung sounds as well, can't you?
We examine the lungs because chest pain can be from lung problems as well. I mean, we always talk, whenever there's a patient and they want to know, why am I having chest pain? We talk about what's in the chest, your bones, your skin, your muscles, the heart, the esophagus, the lungs.
Okay, so Dr. Melton, so if someone comes in with chest pain, of course you're going to read their vital signs as the nurse is taking. You're going to take a history. You're going to examine them physically, do a physical examination.
Right.
So what are some of the more common tests that you might order in a workup for chest pain?
Well, the most important test that we want to do right away, as soon as possible, when someone comes to the emergency room with chest pain, is an EKG, an electrocardiogram. And what that is we just put stickers on the chest, and the stickers record the electrical activity of the heart. They don't actually do anything to you. They're just measuring the electricity that the heart emits. And That is our most important test, and that test can make a huge difference in what we do in the first 15 minutes of the visit.
So by reading the electrocardiogram, you get an idea of the electrical signals
Exactly.
that are actually being emitted from the heart.
Right.
For example, the electrodes don't touch the heart. The electrodes don't touch the heart itself,
Right.
but they're attached to the chest skin.
Exactly.
And perhaps the belly skin.
Right.
Somewhere on the
stickers.
thorax.
Yeah, exactly.
Right. So you can get an idea just from the electrical activity what might be happening in the heart.
Exactly. And one of the great things that's happening now in Monterey, as well as all the way across the country, is that the paramedics are actually doing EKGs before the patient even arrives to the emergency department. And we are just starting to get the technology where doctors, emergency doctors and cardiologists can actually see the EKGs before the patient comes to the hospital.
Well, that's really fascinating. So what are some of the clues that you can get by looking at an EKG about what's going on in the heart? What can you tell?
Well, without getting too technical, by looking at the electrical conduction, we can actually see sometimes when the heart is not getting enough blood. If there's a blocked artery, the EKG can show us that. And there's a word we use called a STEMI. I won't go into what that stands for, but
now, Sam, I think you're going to teach me a lot during this episode.
Right.
So maybe can you tell me what that stands for? Is it STEMI?
It stands for ST segment elevation myocardial infarction. It's a very long word for what the public would call a heart attack.
Okay. All right. So you can oftentimes see that right on the EKG.
Right. If it's a major heart attack, a blocked artery, the EKG will usually show it. And if we see that, at least at CHOMP, what we do is we activate a cardiac catheterization code, and a whole number of things happen to assemble a team to open up that blocked artery.
That's amazing. So right there in the emergency room, you can sometimes diagnose a myocardial infarction or a heart attack in progress and try to do things that prevent it from getting worse or progressing.
Exactly.
So what are some of the other tests, like I think you guys order enzymes, which I want you to teach me about.
Yeah.
You take a blood test. Sometimes you order a chest X-ray, et cetera, right?
Right, exactly.
So what do you look for on chest X-ray?
Chest X-ray, we're actually looking for problems aside from a heart attack. So there are a number of other causes of chest pain, just like you mentioned, and some of them you can diagnose with a chest X-ray. A punctured lung can cause severe chest X-ray. That's called a pneumothorax, and that can happen spontaneously or from trauma, and we look for that. We look for fluid on the lungs. We look for a very rare but serious disease called an aortic dissection, and we look for pneumonia. I mean, there's probably about 50 things we look for.
It can give you a lot of information. Just simple chest X-ray can be a very sophisticated test.
Right.
Now, Dr. Melton, I told you ahead of time that I like to learn during these segments. So if you can teach me and our audience what we mean by cardiac enzymes or isoenzymes, correct? Now, so teach us what that means when you order the tech or the nurse to draw cardiac enzymes. What's that mean? Yeah,
so they're blood tests, and they're actually fairly new. I think they've been around for about the last, well, at least the one we use now called the troponin has been around for about the last 20 years, I believe. And it has really revolutionized our ability to detect very subtle blocked arteries in the heart or coronary artery disease. So typically, if the patient comes in and the EKG does not show a major heart attack, we're all very happy about that, but then we worry, is there what you might call a minor heart attack or just chest pain that's serious but not a major heart attack? So we use this blood test called a cardiac enzyme or a troponin, which the troponin is part of the heart. It's a tiny little molecule, a protein, in the heart muscle that should really only be in the heart muscle in a healthy person. So we take the blood test, we measure the level of troponin to see, has the heart undergone damage, and is that protein leaking out into the blood, and we can detect that. And if that's the case, then we need to typically admit the patient to the hospital for further testing to figure out where is the blocked artery, is this from a blocked artery. So it's a it's a really important test, and it's allowed us to really become very sensitive, very advanced in our ability to detect coronary artery disease.
Oh, okay, Dr. Melton, and I appreciate you teaching us about that, including myself.
Right.
So technically, when we talk about a heart attack, that's a myocardial infarction.
Right.
That means the cardiac muscle, in other words, the muscle of the heart itself, is not getting enough blood supply.
Right.
And it starts to undergo some damage, and that enzyme is released into the bloodstream.
Right.
So you can actually measure that.
Right.
That's amazing.
Yeah.
So let's back up for a moment.
Mm-hmm.
Let's say it's a 50-year-old guy or woman who's out in town having a big meal, maybe spicy, and after the meal they feel some pain in their chest, and they're not sure if it's pressure, they're not sure if the food was kind of spicy, and they come to the emergency room. Is that a good idea? Like, does anybody who's having chest pain, is that important for them to come to the emergency room?
That's a great question, and that's one of the hardest questions to answer because, like I said, just based on history, sometimes we can tell you that the chest pain is nothing serious, but more often than not, we need to run tests because we don't feel that it's good enough to even miss 1 out of 100 serious causes of chest pain. And when we look at the big studies, when we do the history and the physical exam, especially on an adult, there needs to be something really clear to prevent us from running tests. There needs to be something really convincing to us. We always want to err on the side of caution. So I would say that if someone is having chest pain that's unusual for that person or concerning or it just doesn't feel right, that they should be checked out by a doctor or in the emergency department because unfortunately heart attacks do happen with symptoms like heartburn or nausea. So I wish I could say if you're having these symptoms you don't need to go to the emergency department, but still we don't quite have that ability to tell people just based on what you're feeling you don't need to be checked out.
Well, Dr. Melton, I think that's a great take-home lesson, and we only have a few more seconds. But one common question that I think we all hear about is why do people sometimes have to stay overnight or be observed, even in the emergency room, if they're not admitted to the hospital?
Right.
Why is it that the emergency room staff often recommends that they be observed for 12 hours or even longer? Why is that?
Right, I'm glad you asked that question because that's the question I hear most often. I hear that question 2 or 3 times a day, which is, okay, so we've done the EKG, we've done the chest X-ray, we've done a cardiac enzyme, and everything looks okay. I want to go home. Why do you want me to stay overnight? And the reason we do that is that the American Heart Association recommends that in patients with what we call intermediate or high-risk chest pain, meaning we've talked to you, we've done the exams, and we're concerned. There may be a blocked artery in the heart, we're not sure. They recommend what we call serial cardiac enzymes, meaning just one is not enough. And the reason is it may take time for that muscle that's leaking out into the blood to be detectable. And it's usually somewhere between 12 and 18 hours. And so typically that involves an overnight stay. And they also recommend for intermediate or high-risk patients that they undergo what's called a stress test. And that doesn't mean, we give you a exam and try to stress you out. It means basically you walk on a treadmill. We do the EKG while you're walking on the treadmill. Sometimes we do what's called an imaging study of the heart as well. And that allows us to detect, is the heart getting enough blood flow? Is the heart getting enough oxygen? And so I tell my patients, everyone knows to go to the ER if you're having serious chest pain. No one knows that you should bring your pillow.
Okay.
Because it's typically an overnight stay.
So it's part of the so-called workup.
It is.
That's very important.
Yeah.
Well, Dr. Sam Melton, you are board certified
Exactly.
in emergency room medicine, and you're from USC.
Exactly.
I love that.
Yeah.
Dr. Melton, I really appreciate you coming on the program.
Yeah.
It's a very valuable public service, and I hope you'll consider coming on again.
Oh, definitely. Thank you so much.
Thanks for being here.
Okay.
Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health television program. We're going to come right back after a very brief pause for a very good cause. Please stay tuned.